to think about. So there's polymyositis, dermatomyositis, and inclusion body myositis. So we're going to talk about a few of the features. And again, we're going to spend some time talking about the pathological features. But just to reemphasize, our main job is to make sure that we have a good sense of what the differential diagnosis is. So we don't just send a prayer up there for Dr. Gokten to look at and then hope for the best. That's the worst thing we could do. It doesn't help anyone.
At which point I will start praying too.
Yeah, or you might fill my car with balloons or something like that. All right. So the first one we're going to talk about is polymyositis. To me, it's sort of the first one that I think of. You're looking for, as we've been talking about, symmetric proximal weakness. Happens relatively quickly, within a few weeks perhaps. Things that I look for in addition to that are, on biopsy, we'll see some inflammation, which I'll have Dr. Gokten talk about. It is important to make this diagnosis because these folks have a real good chance to get treated. So we look for immune therapies. So you'll hear about these if you haven't already. Oral prednisone is an option. Sometimes we'll use methotrexate. Sometimes we'll use azathioprine as another option as well. There's a few other options. But if you make this diagnosis, we're able to come up with a plan to treat these patients and get them better.
It is interesting. Every once in a while, I get this opportunity to see what you guys do based on certain diagnoses, and that really stresses me out. Otherwise, we forget about that part of the business hiding behind the microscope.
Yeah.
So that's a good reminder. Thank you. We talked about general myopathic changes, and let's see if we can find some of these over here. There are some really atrophic fibers, and it is impossible really to see everything in one picture, but here mainly we see a fiber size variation with atrophic fibers, and obviously since we are talking about itis, we have a lot of inflammation. These are small lymphocytes, and note that they are within the endomysium. So that is an important clue to this disease. And so we have a myopathy, and on top of that we have inflammation. Therefore, we're talking about inflammatory myopathy. The other disease that goes along with this is
Dermatomyositis, right. And so for this one, it's very similar in some ways, but it has some unique features which are important to note. So there's also that subacute, relatively quickly acting, proximal more so than distal weakness, sort of the same pattern that we see in polymyositis. The big thing that you want to look for before you jump to a biopsy are skin changes. You see that in almost 2/3 of patients, and that's often the presenting symptom. So you can see like a heliotrope rash, a big rash over here, some really notable rashes. One other thing to note is that this can be associated with a malignancy in adults as well. So that's something to watch out for if you make this diagnosis. It is also important to make this diagnosis because just like polymyositis, it responds to a lot of the same immunotherapies that we had mentioned for polymyositis as well. And then there's some features with the dermatomyositis on the muscle biopsy that are notable too. Can you go over that?
Yeah, sure. But it just came to my mind that do you have that association in some cases of polymyositis?
Yeah, you do sometimes.
Yeah.
Yeah.
Okay. But dermatomyositis is more famous for
it's a little more famous for it's a little more, I shall say, buzzwordy.
Okay.
But in real life, you keep them both in mind.
Okay,
yeah.
Sounds good. You can, of course, go back and forth while you're studying between the pictures, but in this case, here we have a fascicle of myofibers. Note that there is not much increase in the endomysial connective tissue and not much activity there either. Everything looks pretty unremarkable. But when you get to the periphery of this fascicle, all of a sudden you start seeing a whole bunch of atrophic fibers. This is called perifascicular atrophy. That's a very specific finding for this disease. In addition, note that perimysium has some inflammation. They tend to be a lot of times around blood vessels, but not necessarily. But the point is that instead of endomysium, as would be in polymyositis, they are now in perimysium. These are two similar sounding, but quite different, histologically quite different diseases.
Yeah, the way that I've always remembered it, because I'm not a super genius, is that I think about the issues with the polymyositis being internal to the structure you're looking at. So you're looking at the muscles more specifically clinically, and then for for the biopsy, you're looking at the endomysium, so almost like the inside of that muscle unit.
Yeah.
And then here we're looking at the skin, so the outside of us, and then the outside of that muscle unit here. That's always been the way that I've thought
Yeah,
about
that's
it.
a good approach to
Yeah.
remember these differences.
Yeah, it helps a simple mind like mine keep things straight.
Yeah, I'll use that too.
All
That's
right.
very appropriate for me.
All right, I think we have one more inflammatory myopathy to talk about.
Exactly.
All right, so let's talk about inclusion body myositis. So we include this one and we mention this one because there's the most important thing, I think, is that if you make this diagnosis, unlike the other folks we've been talking about, these guys don't react to clinical treatment the way that dermatomyositis and polymyositis do. So you can give these people tons of steroids, they'll just gain weight and have other side effects, but they won't get better in terms of their weakness. Clinically, the things that I look for, there's a couple of things that you can see first. One is finger flexor weakness, which is a difference from what we've been seeing. We've been talking about shoulder and hip weakness. And then you also see quadricep and sometimes hip weakness, but that pattern of thigh weakness and finger flexor weakness is what I think of with inclusion body myositis.
It is, I believe, the most common muscle disease over the age of 50
I
or
believe
so.
that is true as well.
So it's actually very common. And unfortunately, finding these diagnostic so-called rimmed vacuole or inclusion body is not always possible in a given muscle biopsy. Sometimes there are a lot of them, sometimes not. So in a given case, if I cannot find them, but if I am convinced that this is in this group of inflammatory myopathies, I will make such a diagnosis and make a comment. And that's why sometimes the patients are treated as polymyositis, for instance, but will not have any response. And then we can retrospectively conclude that, oh, wow, you know, maybe this was a inclusion body myositis. And so that makes a very interesting clinical situation.
It does happen a lot.
Please also note a few things here. When we talk about inclusion, we are not really referring to a viral disease. It looks like an inclusion, some granular membranous debris in this degenerative vacuole. Note that there are some fibers that are splitting, which is another myopathic change, an atrophic fiber, an internal nuclei or nucleus or two. And this is a myopathy. They may have secondarily some inflammation, but not as prominent as polymyositis or definitely not dermatomyositis. But there is a lot of overlap. And another word of caution is that because we're talking about a group of myositis diseases, we still exclude all the other, for instance, a parasitic infection, an abscess. These are not included in this particular group when we talk about inflammatory myopathies.
All right, so this is just a summary slide of inflammatory myopathies. Remember, we just went over 3. So polymyositis, dermatomyositis, and inclusion body myositis. We won't bore you by reading this entire table. You guys can do that on your own. But let's move on now to congenital myopathies.
Sure.
Let's do that.